Hello, everybody. This is episode 63 of our podcast, Artificial Intelligence and Cybersurgery. It is the official podcast for our journal, Artificial Intelligence Surgery. My name is Andrew Gums. I'm here with my co-host, Dr. Vincent Grasso, who will introduce our next guest and hopefully use our tagline.
Yeah, thanks so much, Andrew. This is exciting. We have Michael Salavracos on. He's a radiologist from Belgium. He's got a very interesting company called SurgiPrint that does a lot of transformation of 2D files into 3D reconstructions to help our surgeons, especially the hepatobiliary community, perform their magic better. Mike, it's a great pleasure to have you on. Can you introduce yourself a little better to our audience, and welcome to the 63rd podcast.
Yes, thank you very much to inviting me. So I will try to do my best in English. I'm a radiologist, and during my residency, I focused on work to make 3D models for HPB surgeon, so hepatobiliary pancreatic. The objective of my work was to help surgeons to see better the vessels and the tumor in 3D. So as a radiologist, I can see the CT scan of the MRI, and in 2D, we would construct the anatomy of each patient in 3D models. This is what we are going to do.
So I wanted to point out that our tagline, our journal is the first journal to focus exclusively on all things artificial intelligence and surgery. But radiology is a huge part of surgery. Obviously, if we can't see, we can't operate. The older I get, the more I rely on preoperative imaging. Actually, I would have thought it would be inverted, but the older I get, the more and more I rely on it. There are a lot of companies that do this reconstruction. What do you offer that's different, and how do you think it can be automated in the future? Like, why are you still in the mix? If you can explain that.
Yes, very nice question. So for the first things, at SurgiPrint, we focused on the hepatobiliary and liver surgery because it's the most hardest way to make a reconstruction in 3D. In fact, if you ask a computer to make to see the difference between bones and lung, it's very easy. So we didn't focus on anatomy with already made because it's easy. But in the liver, it's very complicated to see the difference for a computer between the healthy liver and a tumor. So this is why we focused yes on the liver and the pancreas. So the other company, most of the company focused on like lung detection or nodule detection in the lung or tumor in the lung, and or of course of the bone tumor, because it's easier to do that. The second thing is, can we do it automatically? It's a very nice question, because at the beginning of our company, I didn't trust that it's possible for a computer or of course an AI to understand the difference between of course the portal vein, the sushepatic vein, and a tumor. So of course I did it all manually. It take Just to give an example, for one model, it takes like two or 3 hours just to make one models, because you have to paint it slice by slice, and it take a long time to do it. But of course, you will be you can rely on. And
Well,
The
couldn't you
yeah.
use radiomics, like an analysis of the voxels, to tell better? Couldn't a computer tell better what tissue is what if you use radiomics and analyze the voxels? Or
I
is
think
that what you do also?
yes, yes. No, no. You can do it, and the computer are better and better and understand better who what is tumor and what is healthy liver and what is vessels. So based on all the segmentation I made during 2 or 3 years, we trained an AI, and now I can't imagine that an AI can do that, but the AI does it. It detects directly the tumor, so I don't have to do it for hours and hours. So yes, but at the beginning of the SurgiPrint, I'm sure we cannot do that.
You had to,
The
had to teach it. You had to teach the AI.
yeah. But no, the AI is teach it, and we can do it. Yes, we can do it.
How long does it take now? Can the AI do it autonomously now? Or you still
Um,
need to control it?
yeah. If if the CT scan is well injected with a good contrast, I think with my computer, because I bought a very strong computer, it takes like 7 minutes.
Okay. But do you have to go, do you have do the annotation anymore, or your program does it now?
The program does it, but as always in AI and in radiology, and I think it's the future of the radiologist generally. I have to make a last check if I
Yeah,
can
of course,
tell
of
that.
course. Yeah.
So
Yeah.
and it's very interesting because all the new tools in AI in medicine, but of course in radiology, will be like that. The workflow will be like that. The last check will be done by a radiologist. So it's very interesting. Yes.
Well, I mean that just opens up such an interesting can of worms, because now what you're telling me is your AI can read your film for you in 7 minutes, which normally took you before. I'm just talking about reading an image. Before it would take you at least, I would imagine, 30 minutes to read a whole CT scan, right? Or maybe 20 minutes, 15 minutes, something like that.
Yeah.
Now I'm assuming you can cut that time in half. Let's just use a number, make it simple. Do you think reimbursements are going to go down for a radiologist? Because now you can, what you're telling me is you can do twice as much work, or the same amount of work in half the amount of time. You just need to validate it. How do you think it's going to play out?
Yes, maybe the reimbursement will decrease, and it's a good thing. Why not? Um, the things also is the volume of the workflow of a radiologist still growing up. So the the workday will will not decrease. Maybe the reimbursement will decrease, but it's not a problem.
Oh,
The day will be the
interesting.
same.
Well, that's interesting, because when I give lectures to medical students, and I tell them I'm worried about the future of radiology and dermatologists, because of the power of AI in encroaching on these fields. But that's interesting. You tell me, if anything, there's more studies being done now, not less, which will counteract any effects of reimbursement, which unfortunately is something we need to worry about for the next generation.
Yes, sure. But as a radiologist, I'm not. I don't want to be totally. S- don't want evolution. We have to go in the evolution of the work, and even if the reimbursement is decreased, no problem with that. We have enough work for everybody, so it's not a problem.
Well,
Um,
it's so interesting, because I think about it for dermatologists. Even now, you're right.
mhm.
Now someone has to go in, they have to take off all their clothes, stand there. The radiologist, has to spread their cheeks, has to look and everything. And it's really time consuming and what have you. But if there is a way you go into a room, a computer takes a picture of your body, analyzes everything, then that would create, you could see so many more patients. You could actually impact and eliminate death from melanoma. And
Sure.
just like you say, it would actually maybe eradicate death from melanoma. Dermatologists, maybe their reimbursements goes down, but now they start seeing everybody. I don't know why I never thought of it that way, but it's
Yes, but
there's
I
hope
don't
for us,
know.
Vincent. There's hope for us. I wonder if surgery will have the same phenomena, in the sense that more procedures will be done. I guess we're kind of seeing that in things like bariatric surgery, Vincent, right? I mean, who would have thought that surgery would become a viable treatment of a disease like obesity and diabetes, but here we are. So
But in fact, I don't know how what is the time that patients have to wait for to go and to see a dermatologist. But in Belgium, it's like 6 months.
absolutely,
So
absolutely. Well,
no,
you can
no,
have it on your phone now. On your phone, you can take a picture of a lesion. I think you pay like $8 a month. You get a subscription, and it'll tell you whether it's concerning or not. So think about it. Now everybody on their phone has this. How many more people are now going to need an appointment to see a dermatologist? You know, millions and millions more. Uh,
sure.
so, oh, I love this. This is a very hopeful episode. This is great. Um, you know, before we dig even deeper into your company, you know, I didn't ask, you know, I like to know the background, why you became a radiologist, where you come from, just to get an idea. And then I also want to talk about your brother, because you guys have two very different pathways, but you are working together. So I'd like to hear how that evolved.
Yes, yes, very nice questions again. Um, so we are three. So I have one big brother and one big sister. My father is family practicer, so it's a general practicer.
Yeah,
So for all of my life, we were between medicine with my father, and my mother is a physiotherapist. I think we say it like that.
yeah.
And I always want to be a doctor. I don't know why. So I don't have any more memories that I don't want do anything. Oula.
Oh, yeah, yeah.
Be a doctor. Okay, you understand me?
No, but by the
And
way, your English is excellent. I'm very impressed. Very good. I'm very impressed.
uh,
I hope my French is this.
I try. So yes, during the medical school, um, I want to be a radiologist because I was a little bit like a geek when I was young. So when I'm on a computer, I'm really relaxed with a computer. I like new technology. I like that.
Yeah.
So the best way to between a medical school and technologist radiology. So this is why I choose radiology here. And so at the end of my residency, we have to do like a big work. We call it memory, or the final work of your residency. And I saw that we can make some 3D models. And a surgeon works in my hospital is Laurent Coubeau. Asked me, "How can you make a 3D model for me and show me where is the portal vein and the tumor? It will be very helpful." I say yes, no problem. And at the beginning, um, we printed the 3D model. So we had like a big model, a physical model that surgeon put in a sterile bag and can show the 3D models during the surgery we in the sterile bag. And the result was very im impressive,
Impressive, impressive, yeah.
impressive. And he asked me another model, and again another model, and again and again and again. So
It was
I
taking you
asked,
2 hours. It was taking you 2 hours each time he would ask you.
yeah. Always. So okay, I didn't have any business background, but my brother has a business background, And I asked to my brother Anthony, okay, let's make a company. I think there is a good business, a good bargain. I think we say it like that.
Yeah, yeah.
And
Consider to make money. Yeah, good.
yeah,
Bonne affaire. No?
bonne affaire. Yes, 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 yes. Bonne affaire. And he was living in Dubai, and we printed the 3D models in Dubai. And after that, we shipped it everywhere in the world with a DHL. So we send the 3D models in everywhere in Europe. And
So hold on. When I met you first, you sent me a virtual 3D model. Are
yeah,
you But you started printing them also?
no. So after that, we stopped the 3D printing model
Ah,
because it was
too
too
expensive.
difficult. Yeah, too difficult to be on time. Her model was were blocked on the airport, and it was too late, and sometimes it comes broke. Yes, yes, always blocked on the airport. I think they were thinking that we were hiding some drugs, like I don't know what, I
Oh
don't
my
know
God.
what.
Oh,
Yeah, yeah.
yeah.
So, so it was yes too difficult, and in fact, the surgeons asked us to just give us a 3D virtual model. It's enough, and in one click you can show the 3D virtual model.
Yeah.
Mike, thank you. This is exciting. You know, it's nice for our audience that's, you know, physicians, even surgical residents, students, like business people. It's not easy to launch a business, right? So you have a good idea, then you need to raise some capital, and you take a lot of risk. But it looks like you've got a very interesting company afloat, and two of our board members, Noureddin and Mohammed, I think, are part of your team. What's your
Yeah.
next steps? What are you going to do moving forward? How is the company expanding now? What's your growth
Yeah.
plan?
Yes, yes. So for the moment, we sell our models in a country without insurance for civil, and so it's easier to sell it in like Dubai or in Brazil or in Romania because the surgeon can direct put the price on the patient, but it's not ever reimbursement.
Okay.
And for the moment, our most target is to be reimbursed by the insurance. So everybody in Europe, of course, and after in the US can use it. So this is our main focus for the moment. About our raise capital, we go with IMEC. I start with an accelerator in Belgium, and we raised 100K, and it allowed us to develop our AI, of course, huh? To make the automatics and monetization, and to develop the company with software engineering, data scientist, and all kind of this guy.
That's
Nice. So
that's
you're
exciting. That's
that's exciting,
exciting.
right, Andrew? It's fantastic.
They've done you guys have advanced in leaps and bounds. That's fantastic.
Yeah.
So I'm wondering how we can we probably have to discuss offline because your company is growing and I'm very happy to hear that. Yeah.
Yeah. Yes, thank you very much. And of course, it's difficult. Huh? It's not always a simple way, but it's also exciting because in business you have like up and down with your emotion, and sometimes very good, and sometimes you you just lose, and it's like that.
Andrew, we have to talk some more about this because we may be able to help with some of our relationships here and there. And you know, Mike, we have a lot of relationships with surgical departments and training and residency, et cetera, et cetera. I mean, perhaps we can help you here in US with some research projects that would give you some exposure. You know, we can talk about those things. It's exciting. Do you also provide on your platform the ability of flying through, for example, the data set in the visualization? I haven't seen the demo yet. So how involved is it?
Yeah, thank you very much, and for making a relation. Of course, we are interested by that. For the moment, we keep our software for us, but at the end of the day, and of course in the future, the objective is to switch our business model like a SaaS, of course, that
Sure.
surgeon doesn't have to send us the data, because of course this is a big point, a big pain point, the sending data, the DICOM, the anonymization, the AGPD in Europe and in the US. So if we can develop in-house platform for each hospital,
What's
they don't.
LGDP?
Hmm?
LGDP in America and Europe? What's that? LGDP, you said?
GDPR.
GDP,
Oh,
like
What's that?
HIPAA, privacy, security
Oh,
stuff.
yeah.
it's you can't just say HIPAA. There's a new term.
Oh,
Huh?
Europe, yeah, the
In
Europe.
Europe, yeah,
Yeah.
in America it's HIPAA. In Europe, okay, that's
Ah, yes, it's HIPAA.
yeah, HIPAA, HIPAA.
Yeah.
HIPAA. Okay, okay, okay. Yes,
And when
yes,
you
it's
said GDPR in America, I was like, what is that? But
yes, yes, yes. So yes, of
HIPAA in
course,
Europe, yeah,
GDPR. And
okay,
yes, because one, I have a surgeon in Deutschland, in Germany, sorry,
Yeah.
Germany, want a 3D bundle, but cannot send me the DICOM. It was too difficult just to send me, even it's in anonymized, and so it's very complicated.
unbelievable,
Mm.
unbelievable. Yeah, yeah. Well, that's good. So you now what is I guess you're at the stage where you're worried about competitors, right? There must be that you must have quite a few competitors at this
Sure.
point.
Yes, yes, sure. We have competitors, and we saw around us that our competitor were bought by big company, by big tech company. So the for a big tech company like I don't know, Davichi, Medtronic, Karl Storz, and all the big tech,
Yeah.
they 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 buy this kind of company and just had a tool for the surgeon or for robots. For the robotics, surgery is very interesting too, of course.
Yeah, no, that this could be this could be an interesting adjunct. It's hard, Vincent, we've talked about this. It's hard as a business model, because a lot of 3D reconstructions already exist, right? Where the whole thing is 3D reconstructed, or the local radiologist can do the reconstruction. And, you know, have you figured out a way for the radiologist to get paid for this, or for even you to get paid for this? How does, do insurance companies pay for this, is what I'm getting at, for this extra service?
So for the moment, no, of course,
Yeah.
but we're in the process to be reimbursed by the insurance. And as we said at the beginning of the podcast, I think the next step and the next word for radiologists is just to click a button, to wait for the 3D models, and to do, okay, this is a good 3D models. The tumor is well painting or well.
Accurately segmented,
Yes,
everything, yeah.
and just to check the accuracy of the 3D model, I think we are going in this way.
That reminds me, I would like you to define segmentation for our listeners. How do you think of segmentation? A lot of people use the word, a lot of
Mhm.
people are using it improperly. So how do you define segmentation?
So to understand a segmentation, you have to understand how a CT scan works. So when you see a CT scan, it's just like you be cut in slide by slice.
Yeah.
And when you do with your mouse like that, you see in your body slice by slice. But in fact, it's like two D images. So you have to imagine in 3D how your anatomy is. So the segmentation is to paint structure anatomy like a vein, an artery, a tumor, an organ, whatever, and to paint it on a software and to make to make a 3D representation of what you want to have. So this is the segmentation.
So usually I use the term annotation for that. Like you annotate the different body parts. Do you use those terms interchangeably?
No, because for me, an annotation is really an annotation. And you write something, like if you make a virtual colonoscopy, okay, you see a tumor and you will just write right on the colonoscopy. Okay, this is a tumor at the end of the right colon, whatever. So an annotation for me is like you write something. It's not a painting something. But yes, of course, the terms are very very close. Huh? Of course.
Yeah. So I guess that there's a little bit of
Yeah.
a gray area because I imagine you have a CT scan and you wanna draw the portal vein. You're annotating it. You're writing it. You're making it blue.
Yeah.
I would think that would be annotation, but
Well, yes, well, yes, of course, yes, it's a gray area. But for me, an annotation is like if you detect a nodule of the lung and you think is a bad nodule or a tumor, you make just an annotation. Okay, be careful at this slice because I think this is a tumor. But yes, okay, it's the same.
All right, interesting. Very interesting. So, guys, as you can see, we don't have much time left. So Vincent, I'll let you close it out. Do you have? And I apologize, but I got an Amazon package for our podcast. Sorry about that. No one else is home but me. But Vincent, please, I'll let you close out the podcast.
Thank you. This is so exciting, and we'll continue with Mike and talk about some of our projects and how we can help him with some of our relationships and studies.
Thank you very much.
So episode 63, right, Andrew?
Season 3. Yeah. So Mike, please, we're gonna stop recording, but please stick around, okay?
Okay.
Thanks, everybody.